So it's my great pleasure to welcome and introduce the keynote speaker for the first Asia Pacific Conference. It's Dan Raymer, who's a good friend, mentor, and colleague of mine. Dan practices at Harvard Medical School as Associate Professor of Anesthesia. He's a bioengineer by trade in the Department of Anesthesia and Critical Care at Massachusetts General Hospital in Boston, USA. His position at the Center for Medical Simulation is Director of Research and Development. He was one of the founding trustees of the International Society for Simulation in Healthcare and past president. Recently, he achieved a Lifetime Achievement Award as awarded by the Society for Simulation in Healthcare. And his expertise, as many of you know, amongst others, is in debriefing, teamwork, crisis resource management, as well as leadership. And so I think we're incredibly lucky and fortunate to have Dan join us here today for the conference. So please join me in welcoming Dr. Dan Raymer.
Thank you, Adam, for the kind introduction. It's thrilling to be here and be part of this first ever Asia Conference on Simulation in Healthcare. As one of the founding trustees of the Society for Simulation in Healthcare, I know it was in the original vision of people who gathered to start a simulation community that it be a global community where people from all over the world would gather to discuss common interests in this topic area. So I'm very honored and very proud to be here and be part of this conference. Slides? Great. So I think Adam invited me to be the keynote speaker mostly because I'm old. He asked me to talk about the past, the present, and the future. I guess you need an old person to talk about the past and think about the future. So I'm going to try to do that over the next 35 or 40 minutes. If you look at the growth curve for simulation, it sort of looks like this by any measure. So if you look at the number of simulators sold throughout the world, or the number of instructors trained, meeting attendance, how many papers get published, how many simulation centers get started, the curve looks something like this, a long flat period from 1900 up until somewhere around 1985 to 1990, and then a very steep upslope, the period that we're in now. So I started thinking about this curve. I was around for the flat part of the curve. And I knew my calling. I knew I wanted to play with dummies. And so I'm thinking maybe I missed something during that flat period. And I started thinking about what was missing. What was missing for all of those years when simulation was quiescent before this uptick in simulation. So my objectives in this talk this morning are to try to understand why simulation has been absent from healthcare education, or virtually absent from healthcare education from about 1900 to 1990, why it has suddenly emerged in the past 2 decades, and make some predictions about whether it will continue on this steep trajectory or flatten out at some point in the near future. So I like to eat, and I thought about coming to Hong Kong and the wonderful cuisine that you get in Hong Kong. And so I was simultaneously thinking about the topic of of the time course of simulation, and I thought about, what are the ingredients that you need to make a recipe? And so the banquet of simulation needed ingredients. Maybe some of the ingredients were missing. What was missing? So I've talked to a lot of people about this, and I've heard discussions about why simulation suddenly has come upon us. And so some people say simply that the idea of simulation was undiscovered, that it was just waiting for someone to come up with the great idea of using simulation in healthcare. Some people say the technology was inadequate, that it would take the computer age to advance simulation to the point where it would be useful to us. Others have argued that there were no champions, no people with enough passion or enough willingness to push the idea of simulation forward and make it happen in an unfriendly healthcare world. Others, the skeptics, always cite, well, there was a lack of evidence, and there's still a lack of evidence. Does simulation really work, whatever that means? And so some people say there was no proof for simulation, and therefore, why should it emerge? Others have argued that the model of healthcare education, the way we've trained physicians and nurses over the past 100 years, has been perfectly adequate. And although we've made minor improvements here and there, the basic model is sufficient, and therefore we don't need a new technique like simulation to disrupt the model of education that we have. Another argument is, and this takes some looking retrospectively, I suppose, that there was no patient safety problem prior to 1990. I guess no awareness of a patient safety problem prior to 1990, and that would be necessary in order to push simulation along. Not a bad argument. And then finally, others point out there was no money for it. There still isn't much money for it, but certainly in the past, no money had been allocated in grants or any other mechanism to pay for simulation and advancing it, developing it and advancing it. So I started thinking about these things, and I like history and I like medical history. I started thinking about when I was a young boy, and were these things really true? So let's take the first four issues. Was the idea undiscovered? Was there not technology available? Were there no champions pushing simulation forward? And was there a lack of evidence? So this takes us back to 1910, around when I was born, I guess. Abraham Flexner was a physician in New York, in the USA, who was commissioned by the Carnegie Foundation to study the medical education model in the United States and Canada. And I got a hold of his report, and I actually read it recently, and it was fascinating reading. I would recommend it to all of you because it described a world in which getting a medical degree meant that you paid $20 US dollars, which was a lot of money at the time, but so long as you paid your $20 and listened to a few lectures, you got to put MD after your name. It was not required that you had to be able to read or write. All you had to do was pay your $20. And so Flexner's report laid out a blueprint for coming up with a medical education model that would have requirements and make sure that people could actually read as they studied physiology and anatomy and laid out the curriculum. And it's really the blueprint that we followed ever since his report. If you read it, it looks just like the system that we have, certainly in Boston. So in reading his report, I came upon an interesting sentence. And I'll read the sentence for you. This was on the section on surgical training, and it said, it was about obstetrical training. It said, obstetrical training pursues analogous lines. After preliminary drill with the mannequin, the student first assists, then has charge under an instructor of the cases in question. So the original model was simulate one, see one, do one. And I guess somehow that got changed to see one, do one, teach one. or C1, 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 but some other model that lost the mannequin. So the idea was there back in 1910. Also, when I was a young boy, I liked to play with dolls. And one of the dolls I played with was a doll called Recessi Annie. And so in 1960, three very clever and actually very passionate individuals put together this doll. So left to right, on your left to right, Bjorn Lind, an anesthesiologist in Stavanger, Norway, got together with a very passionate intensivist from the United States, Peter Saffer, and they collaborated with a very excited and accomplished toy maker by the name of Asmund Lerdahl, familiar name, Lerdahl, and they put together a doll that was called Recessi Annie, and the design of the doll was such that you could ventilate the doll and could do chest compressions, and it had a very realistic, reasonably realistic sense and feel to it. And so Recessi Annie became the ubiquitous mannequin used for training with resuscitation, still used to this day. There's probably one sitting over there. So it really represented the first widespread use of a mannequin, albeit it wasn't electronically controlled. Also back in the mid-60s, there was another development, the Harvey Simulator. And as you can see from this photo, the Harvey Simulator was much more technologically sophisticated. Had a tremendous amount of electronics to it. It was developed, it was invented by still active simulation physician slash engineer by the name of Michael Gordon in Miami, a colleague of Barry Eisenberg. And so this came into being and got widespread use in medical schools around the U.S. and the rest of the world. I learned an interesting fact in looking for this picture of the Harvey Simulator. I always wondered why they named it Harvey. It turns out it was named after a prominent cardiologist by the name of W. Proctor Harvey. And Wikipedia is wonderful. I got to read about Dr. Harvey and learned that he was synonymous with auscultation skill. So he was a famous educator, a really sought after and beloved educator who it was said could make 90 to 95% correct diagnoses just by carefully examining a patient and by listening carefully. And so his great skill was turned into a technological simulator, one that I actually used in my hippie days when I was took medical school courses. And then what about this?
With blood pressure and pulse still normal, he is given a second larger injection of sodium pentothal, followed by one of suctional choline to relax his throat and chest muscles sufficiently for the doctor to perform the intubation. The fluttering movement of muscles in his chest indicate that the
Notice the fasciculations in the chest.
Now, the face mask is removed and the laryngoscope inserted. With no time to spare, because the endotracheal airway must be in position before the patient's oxygen supply is seriously reduced, the airway is quickly inserted directly into his trachea. Its depth registered on the console. A bright block is inserted to protect the airway. The cuff is in place. With the airway connected to the anesthesia machine, only the controlled mixture of oxygen and anesthetic gases can enter his lungs. from now on until the effect of the muscle relaxant wears off.